So when you are on duty, one of the commonest things for which we are called for is a patient having fever. Now, amongst various patients with fever, there are some whose vital signs are rapidly fluctuating. There are some in whom the blood reports are rapidly fluctuating. The counts are varying. Some are unstable, some are stable. You may not know the exact diagnosis right at that moment. But these are those typical 3 a.m. moments where we still have to make a decision. A decision whether to act immediately or whether we can wait and observe in some of these patients. A decision about which test to do, what to prioritize, and what treatment to start. Let us discuss through some of the common scenarios about how to think when we are faced with a patient with fever and how to apply what we already know in these patients. So, to start with, any patient with fever, we should follow a certain fixed framework. And this framework involves asking ourselves three important questions. First and foremost, is the patient sick or is the patient stable? Because that will decide how rapidly we need to act or whether we can wait for confirming the diagnosis. Second, is there an obvious focus of infection or the focus is not very obvious? In this particular patient, whether I need to act now immediately or I can afford to wait and observe and then take a call about what is to be done next. There is another fourth subtle thing which we should quietly ask ourselves in some of these situations, and that is the fever really because of infection or is it some inflammation which is causing all the signs which look like an infection but they are not? So, keeping this framework in mind, let us see what happens in real clinical situations. So, our first patient is a young gentleman with fever of 4 to 5 days, typical retroorbital headache, severe body pain, flushing rash on the body. And he has got admitted because even on day 5, he still has fever. And by now, his WBC is dropping, as you can see in the reports. So, platelet counts, which were somewhere around 2.5 3 lakhs to begin with, have rapidly dropped to something like 40,000 in a matter of 3 to 4 days. So I've had instances in such scenarios where the patient and his family literally plotted the platelet chart saying that doc, by tomorrow morning his platelets are going to be zero. Please do something immediately, otherwise he may have bleeding and die of it. Well, that is your 3 a.m. moment. So here the trap is only paying attention to the platelet count and not paying attention to certain other parameters which would be actually far more important in a patient with dengue. Now, in such a patient, it is not important to know that this person has dengue or he has something else which has caused this fever and low platelets. What is important to know is that dengue is not a disease of low platelets. Dengue is a disease of capillary leak and capillary injury. So, in any dengue patient, it is not the falling platelets which cause complications or cause death of the patient in many situations, but it is the plasma leakage which can lead to complications, which can lead to shock. So here, instead of paying attention to only numbers like white cell count and platelet, as a good clinician, we should always pay attention to the disturbing pathophysiology which is occurring in that particular patient. So what are the clues towards that? The most important parameter here is a rising hematocrit. Especially if there is more than 20% rise in hematocrit, that seriously means that the person needs to be hydrated properly. Otherwise, the person is likely to land towards dengue shock and other multi-organ issues in a complicated dengue. Another subtle clue towards this thing happening is narrowing of systolic and diastolic pressure difference. So, on a gross look of it, the patient may look stable. The counts may not yet have dropped significantly. But if the pulse pressure is narrowing, systolic and diastolic are coming closer, then that is an important clue that this person is going towards an impending shock and we need to act really fast. In addition to these two very subtle but important early warning signs, we also need to pay attention to other things like persistent vomiting, severe abdominal pain, hepatomegaly, jaundice developing, liver enzymes going in thousands. mucosal bleeding, the patient looking unusually lethargic or disoriented. All these things collectively, as we call as warning signs in dengue, can point towards impending shock or impending multi-organ dysfunction in a person who may be having a mild to moderate dengue to begin with. And we must pay attention to presence or absence of all these warning signs, because at the beginning of it we may not know who is going to settle and who is going to worsen. So always remember, pay attention to the physiology in dengue and not just the platelet number. So as I say, the 3 AM checkpoints, the checkpoints for all of us to take those sudden decisions, is first and foremost, pay attention to hematocrit, a rise in it rather than just dropping platelets. Second, the real drug of choice when it comes to managing dengue patients is fluids, especially isotonic saline, and it is not SDP or RDP. Third, attend to the disturbance in the physiology in dengue rather than just focusing on the numbers of platelet in that person's reports. And fourth, pay attention to early warning signs like narrowing pulse pressure, postural hypotension, along with all others that we mentioned, and not just the platelet number. Now, here one very important factor I have observed practically, that many times the person doesn't get fluid in time because the sister or the resident keeps saying that line was occupied in giving SDP or RDP. So that is one very important mistake to avoid. If you need blood products also, if there is an active mucosal bleed, the platelet count is below the critical threshold, secure 2 different IV cannulas, but do not sacrifice adequate fluid management just because we wanted to use that IV line for giving platelet transfusion. Also, as the patient goes towards convalescence or recovery phase, all this third space fluid comes back in the circulation. So there be very careful about the fluid balance, otherwise the patient can land up with fluid overload. Now after this case, let us see another situation where we may feel we need to act really quick, but the actual truth could be exactly reverse. Here we have a young patient who has recently undergone ERCP for obstructive jaundice with gallstones. And post ERCP, like as a known complication, the person has landed up with acute pancreatitis. Now, one fine time, you get a call saying that patient has high grade fever of 103 degree Fahrenheit. And when you go back and check the patient's files and everything, somebody would have already written start meropenem, start ticoplanin, because this person has severe acute pancreatitis and may develop necrosis and infections later. Well, this exactly is the trap in a situation with acute pancreatitis. Because in acute pancreatitis, especially very early in the course, in first 3 to 5 days, it is the inflammation which drives all the systemic inflammatory response and not the infection. So the person may have high grade fever, the person may look toxic, person may be tachycardic, they can have severe abdominal pain, vomiting, but may not necessarily be having infection at that point of time. So like in our framework, here the first question to ask, does this patient have infection? Are there signs to tell me that there is infection in this particular patient? Second point is, if you feel there is infection, what is the focus? If you are not able to answer these 2 points, then we should wait and observe in these patients, because in pancreatitis, the initial 3 to 5 days, sometimes even up to 7 days, are driven by inflammation. As we enter the second week, most of the secondary infections, mainly bacterial, start taking place, and that is through essentially GI translocation. So the bacteria which are there in our gut are the usual reason for this infection. And as we move further towards week 3, where the patient may have had lines for a long time, would have received broad spectrum antibiotics, sometimes TPN, maybe necrosis of the pancreas, there comes the fungal infection risk. Again, something like candida, which is a part of gut flora in us. So once the bacteria are controlled, this can cause infection. But early in the course, we have to go back to what we have learned over the years in sepsis definitions. So instead of looking at the definitions or the theory part of it, what we need to understand is what is SIRS, that is systemic inflammatory response syndrome, and what is sepsis. So as the definition has evolved over the years, by sepsis we essentially mean dysregulated host response leading to organ dysfunction all of which is triggered by an infection. So why we kind of have done away with the term of SIRS? Because systemic inflammatory response can happen in conditions which are not because of bacterial sepsis or fungal sepsis in many situations. One of the important ones is acute severe pancreatitis. So there only the parameters like fever, heart rate, tachypnea, uneasiness, patient looking toxic may not be enough to say there is sepsis. So we have to learn here to differentiate what is inflammation leading to systemic response versus an infection leading to systemic response. Now, in this situation, many times we feel what's harm in giving the antibiotic? I might as well give it off because the distinction is never really clear. Okay, day 7, no infection, day 8, there will be infection. Well, that's true. The distinction is not clear. But what we need to remember is that the infection in these patients is not coming externally most of the time. It is coming from the person's own gut flora. So if we give antibiotics, especially broad spectrum antibiotics, too early, they end up killing most of the sensitive bugs which are there in the person's gut flora. And later on, when at times even unavoidably the person does get infection because of GI translocation, only the multi-drug resistant organisms will be left behind. And that makes our tomorrow's job of treating actual infection when it occurs in that patient extremely hard. Always remember, right in the beginning of pancreatitis, it is not the antibiotics which are going to prevent complications or systemic manifestations of severe pancreatitis, but it is proper fluid management. It is managing the person's pain, which will make the person more comfortable, and as soon as possible, start using the enteral feeding, start using the gut for giving that person adequate nutrition. Now, managing this is far more important than jumping onto broad spectrum antibiotics, especially early in the course of pancreatitis. So, what are the 3 AM checkpoints when it comes to severe acute pancreatitis? First and foremost, differentiate what are the signs because of inflammation, even SIRS, versus those because of infection. Second, in acute severe pancreatitis early part, fluid therapy and proper management of enteral nutrition is far more important than jumping onto broad spectrum antibiotics. Third, markers like high WBC count, increased CRP, increased procalcitonin can all be present without infection in early phases of severe acute pancreatitis. But a negative marker like a negative procalcitonin goes a long way in predicting that there is no severe systemic infection at present and antibiotics can wait. Now, contrary to this situation, there may be some situations where your wait and watch policy can be extremely dangerous for the patient. So, let us see one such patient. So, here we have a patient who has come with a history of very short duration of fever, of say 2 to 3 days duration, and after which the person looked confused. And by the time he was brought to the emergency, the patient is extremely drowsy, just about arousable. And when you examine, you find some subtle neck rigidity. So now this patient definitely appears to have a CNS infection or a meningitis. So in this particular patient, we do understand that the person may need CT scan, MRI of the brain, lumbar puncture, the cultures for confirmation of diagnosis. But this is one situation where if you wait for certainty of diagnosis, then you are likely to be already very late. Because meningitis, especially pyogenic meningitis, is one situation where each hour delay in administering appropriate antibiotic can be leading to an irreversible damage to the brain, which may have sequelae later on. So if we keep on waiting for the confirmation of diagnosis, we may end up diagnosing something which could have become irreversibly damaged by that time. So what is important here is to start empiric treatment upfront with the usual ceftriaxone, acyclovir to cover for viral pathogens, vancomycin with or without ampicillin depending upon the patient's age group, the patient's risk factors like chronic alcoholism, eating certain types of foods like cheese, fish, etc. Now yes, we have to do lumbar puncture, but whether to do it after imaging like CT and MRI of brain or before it. So if the person has new onset convulsion, focal neurological deficit, clinically detectable papilledema, or if the person happens to be immunocompromised, like someone with HIV, then always it is imaging first and lumbar puncture for CSF examination later. Now this protocol, where person may easily kind of spend 1 or 2 hours at best of the centers in getting CT or MRI of brain followed by lumbar puncture, should not delay initiating antibiotics. Now, unlike other situations where we always say that give antibiotic only after you have sent appropriate cultures, this is not one of those. You should not delay antibiotics so that your CSF yields towards exact diagnosis are better. No. Start empiric therapy and parallelly keep doing all the workup that is required. Because like we say in stroke, time is brain when it comes to the brain. So every delay leads to some irreversible damage. So the 3M checkpoints when it comes to this scenario, where there is a pointer towards acute CNS infection like a pyogenic or a viral meningitis or meningoencephalitis. First and foremost, start empiric treatment early. So that would include ceftriaxone, vancomycin with or without ampicillin, depending upon those factors. If viral is in picture, acyclovir. Sometimes in the season where rickettsial infections are common, even doxycycline. And in places which are endemic, even antimalarials. Second, if there are those factors that we discussed, do imaging before lumbar puncture, but do not delay treatment for these two things. Third, do not forget that first dose of steroid like dexamethasone along with the first dose or just before the first dose of antibiotic to prevent inflammatory damage to brain leading to cerebral edema, sometimes hearing loss or other focal deficit. And last but not the least, never delay antibiotics to improve CSF yield in terms of bacterial culture. So this was one scenario where we needed to act really quick. But at times we are faced with scenarios where we have done, at least we seem to have done everything in time and still the person may not be improving. So like this gentleman who is a long-standing diabetic person with kind of poorly controlled sugars, who presented with fever history of 3 to 4 days, confused state, low blood pressure requiring inotropic support, tachycardia, and who was in acidosis. And he was taken up in ICU obviously. And now you have started meropenem teicoplanin as the empiric treatment, sending all the necessary cultures like paired blood culture, urine culture, along with other routine examination. You find the sugars are not like exorbitantly high. They are somewhere like 200s, 250s, sometimes going to 300, but not in the range where the person would land up in diabetic ketoacidosis. But ABG is showing metabolic acidosis with increased lactate. So this is a typical scenario of a person with poorly controlled diabetes with sepsis, septic shock, leading to poor perfusion in the tissue, leading to increased lactate and metabolic acidosis. So in such a person, no doubt it is important to control the sugars, but MAP, that is the mean arterial pressure, is way more important than sugar control. So proper fluid management, maintaining the MAP properly above 70 millimeters of mercury, improving the tissue perfusion goes a long way in preventing multi-organ dysfunction like AKI, liver derangement and other complications because of sepsis in such a patient. Now in this gentleman, a day later, you got a call from microbiology lab saying a gram-negative bacillus is growing in the blood culture. We'll give you identity and sensitivity in another 12 to 24 hours. So of course, we'll not go into the details of what other tests to be done and the molecular diagnostics and all in this particular case. But because it was a gram-negative bacteria, teicoplanin was stopped, meropenem was continued. The person by that time had become much better alert with the fluid management. Fever was still coming, although the frequency was decreasing. But his white cell count, which on day 1 was 32,000, had jumped up to 40s and by day 2 it was in 50,000. So somewhere along the way, you felt the patient is not improving. Although grossly, NORAD requirement not completely stopped, some dose is still going on, fever seemed to be slightly lesser, he's more alert and oriented. So there, with a better oriented person, history was again taken. And he told that he had a history of constipation in recent times and always felt pain when passing stools. So thorough examination was done and ultimately that led to a diagnosis of perianal abscess. one of the very important sites of infection in a poorly controlled diabetic person. So after that, a quite required surgical opinion was taken, abscess drainage was done, and over next 48 to 72 hours, the patient improved. Now, what is important here is on that day when you know that a GNB is growing, but the patient is not so much improving on meropenem, you are faced with a decision whether I escalate the antibiotic to something which will cover carbapenem resistant bacteria, or whether I stay on meropenem on which some parameters at least have improved. Should I wait for 24 hours to get the sensitivity, or should I do other tests to find out whether meropenem is working or not? What is most important in diabetic patients is to pay attention to places like their feet, their perineal areas, their perianal areas, because cellulitis, necrotizing fasciitis, Fournier's gangrene, perianal abscesses are extremely common sites of infection which can be subtly present in that patient, and without a thorough history and examination we can end up missing that. And here we also need to remember, in addition to fluid management, one of the most important aspects of treating infection in such critical patients is finding out the exact source. Second, on knowing that focus to see whether there is something which can be done for source control, because no antibiotic in the world, even if shown sensitive in vitro, can improve a patient with an abscess without drainage of that pus. So, like we used to say, sun should not set on an abscess when pus is found anywhere in the body. This is that situation where we need to step back, observe the patient thoroughly, revisit our history if he seems to be not improving in spite of appropriate antibiotics. So, our 3M checkpoint, first and foremost, even if the patient has diabetes, but if he has sepsis and septic shock, in addition to sugar control, what is more important is fluid management, maintaining the MAP and improving the tissue perfusion. So, second point, two bores and two cultures. So, have two accesses, one for giving things like insulin infusion and managing the sugars and other things, and the other for hydrating the patient well, improving the tissue perfusion and blood pressures well. Two sets of paired blood cultures for improving the yield of the causative organism, along with the second culture, that is urine culture, because urinary tract infection is another common focus in diabetes. Third, if a sepsis patient is not improving in spite of fairly well covered broad spectrum antibiotic, barely escalating antibiotic is not the solution. Try to find out if you have actually narrowed down on the correct focus or not, and whether that focus requires a surgical source control or not, because antibiotics do not penetrate well inside the abscesses if they are not drained properly. So any such abscess collection in the body is more a surgical disease than a medical disease requiring just stepping up of antibiotics. So guys, we saw 4 different cases of fever, same symptom of fever, but different clinical situations. So in all these scenarios, if we keep in mind our initial framework, stable versus sick, focus found or not, and whether I can wait or I need to act immediately, and then apply what we know, then we are more likely to make better clinical decisions. Because good physicians, good clinicians do not chase diagnosis. They act appropriately to prevent complications which can arise out of those diagnoses. Now, in a similar way, there can be certain situations where apparently we would have done everything right, but the patient still may not be improving. So, what goes wrong there? Exactly that is what we are going to discuss in our upcoming video. Till then, keep thinking and keep applying what you already know.